We'll get started with the case. It's an 84-year-old lady with severe symptomatic AS. She's quite a small lady. Her medical history is that of an LAD stent. She's got mild to moderate chronic renal impairment, moderate airways disease, atrial fibrillation, and she's had a permanent pacemaker put in already, which is of some importance in relation to the talk she just heard. She's frail, so her cognitive function is mildly impaired, and she lives at home with her son, good quality of life, reasonably good functioning. Some of her laboratory investigations, the main one probably at the bottom, her pro-BNP is elevated, nearly 2900, mild to moderate renal impairment when you look at the EGFR. This is her echo. I'll leave that running, doesn't really matter. The echo shows that she's got severe aortic stenosis, or confirms that. The peak gradient is 70, mean gradient of 40, aortic valve area and aortic valve area index suitably lowered to fit in with severe AS. Importantly, left ventricular function was normal. There's mild to moderate left ventricular hypertrophy. Carotid Doppler shows mild bilateral disease. Coronary arteries are now pretty much normal, mild coronary irregularity. The LAD stent looks great. And these are some of the CT measurements. The perimeter measured 69.9 millimeters. That puts this patient, if we're talking about an evolute R valve, in between a 26 and a 29, probably on the 26 side. Thank you. The area was 379, so we're talking Sapien S3 valves. It's probably a 23 millimeter valve. Mean diameter of 22.4, again a 26 millimeter evolute arm. Supraannular dimensions were adequate, both in terms of the sinuses of Valsalva. 28 to 30 millimeters is adequate for either of those two valves, and the sinotubular junction was also adequate. It's shown at the bottom on the right, and there is some calcium in the at the sinotubular junction, but the diameters are adequate. In the second, in the picture, second to the from the right is. It shows the coronary sinus, and it shows a moderate amount of calcium on the non-coronary leaflet, which sometimes makes it difficult to place the valve across the annulus. Coronary height was adequate, and the peripheral access, there was a bit of tortuosity, some calcium in the common iliac and abdominal aorta, but the right femoral artery dimensions, as mentioned there, 7.4 by 7.6, more than adequate to allow for a 26 millimeter evolute R valve, or a Sapien S3 23 millimeters, requiring about 5.5 to 6 millimeters of access. This patient was discussed at the heart team, as all of our patients are, and was seen by the aged care team and so forth. The Euro scores and STS scores were high. Clinical and anatomical suitability was discussed, and it was found she was suitable, and an agreement for transfemoral TAVI was made.
Can I ask a question?
Yes, please.
And this don't take this the wrong way, but why are we doing STS scores in Australia?
It's a good question. So as TAVI evolved, STS scores were part of the risk assessment. It was a very important part of the risk assessment to begin with, and it was how the initial trials attempted to differentiate between low, intermediate, and high and extreme risk. It's become less important in the more recent, with more recent developments, in that we take into account overall comorbidity and other factors much more so than STS scores.
And again, just on that point, the STS score is made for North America. There are no African Americans in Australia. That's one of the risks in the STS score.
Yeah.
Other question is, when you did her STS score, did you say she had peripheral vascular disease or not?
No, we didn't. I don't think it was severe enough to warrant under the STS score classification to be included as peripheral vascular disease.
And chronic, and again, this is my point, right?
Yeah,
again, sure. These scores, they're not very accurate. You can make anyone pretty much anything. This lady's got calcification in the peripheral arteries.
Yep.
Some people would actually score her as a patient having peripheral vascular disease.
Well, clearly,
it's just an important thing to remember when we look at scores. They're not a real number. They're a thing that we can use, but we have to be realistic about what they actually mean.
Yep, I think both Ravi and I completely agree with your misgivings of the STS score. Also, there weren't that many 90-year-olds in the original STS database. Okay, discussion points. How do you treat this lady if you go for transfemoral TAVI? Do you give her general anesthetic in relation to one of our talks today, or do we do it under conscious sedation? We elected to use general anesthesia because we were worried she might not be able to be kept still for long enough. Chronic kidney disease, you need to minimize contrast use. That leads to the next point, where we're now using ultrasound-guided access only of the right femoral artery, the point of entry of the TAVI device. Temporary pacing was not so much of an issue during the delivery. We can use an existing pacemaker and pace at a lower rate just to stabilize the blood pressure and lower the pulse pressure to help the valve stay stable. If we have to post-dilate, it's a different story. We need a higher rate and the cardiac standstill. We need a separate dedicated wire. And finally, which prosthesis type and size, we can talk about that. Risk of paravalvular leak with non-coronary sinus calcification, which is somewhat asymmetric and certainly more in the non-coronary leaflet, was worthwhile considering. So, any more questions prior to going on to the case?
The GA versus LA in those really elderly patients is a good thing to discuss. I mean, you can certainly make them still with the GA, but I find that the very elderly do much better with local anaesthesia and with post-operative confusion, recovery, and if you can get by with the local anaesthetic, particularly those very elderly patients, you can talk them through it and give them some mild sedation. I think it's much less morbid than a GA.
Which one?
No, I would agree. We would try very hard to avoid general anaesthetic and including using long anti-local anaesthetic in
Yeah, I think these are issues that we're gradually working through, and I think you have to bring your whole team with you when you make those decisions, and we can all, I think we have certain opinions about it, but it takes a little while sometimes to change, and I certainly wouldn't disagree with your comments, although perhaps in this lady, every now and then you get a valve where delivery is somewhat difficult or protracted, and hypotension can occur, and you definitely need your anaesthetist to be on their toes to keep the patient calm and not moving if they're under local anesthesia or conscious sedation. Okay, we might go on with the case just in the interest of time, if that's all right. If there are any questions during the case, I can pause it and we can answer those questions. Otherwise, we can do it after. And we may need sound on it, please.
Yeah. Full screen? Or?
So we've just got the tip inside the right femoral artery now, and next I'll be applying some forward pressure to see if we can enter the femoral artery with the device. The device may not be quite as friendly to enter with as an actual sheath, but in this case, you can see it's moving very nicely, and there'll be a couple of transition points that you have to negotiate, but in this case, so far, no problem. Sometimes we see some problems in the aorta. There's an angle and lots of calcium. You can see here the device is moving freely and not interacting with the aorta in any adverse way. And the inline sheath is now completely in, and the next step will be to pass the valve around the aortic arch. This lady, as you may have seen on some of the CT images, does have some aortic arch atheroma, and when we go around the arch, we'll do that in the iliocranial view to open up the arch. Ravi will pull on the wire to move the tip of the device away from the greater curvature of the arch. That way, we run a smaller risk of embolizing material from this area. So we like to open up the arch nicely, and so just hold it there. That's great. Okay.
You can see, so you can just see here very gently. As I pull on the wire, you can see it's at the top of the crest. It's moved away. Obviously, the device is fairly stiff, and so there's a limit. And so you can see I've pulled on it, and I'm relaxing it, and now the valve has arrived supraannularly now. So we'll now make everything up and go to our optimal angle, please. And make it up a little more. So
now we'll traverse the valve, the native valve. Now this is one potential problem that we haven't discussed yet. There's a large amount of calcium on the non-coronary leaflet in this case, and I can feel now quite substantial resistance in trying to push the valve across the native aortic valve. And so we may have to use a couple of different maneuvers to try and get it across. For the moment, we'll persist with the safari wire, and I will just apply some more forward pressure. So that's what will happen next.
And obviously you can appreciate that the force has to be controlled, it can't be uncontrolled. I'm going to pull on the wire a little bit just to allow Peter some, just to pull the device off the outer curve, and that's not, so that's
now it slipped across. Yeah. And there was not too much forward pressure, really a bit of manipulation of the wire whilst moving forward and backwards with the valve allowed it to pass nicely.
So now you can see, if we just zoom up another fraction, you can see a radio-opaque marker close to the tip of the pigtail that's sitting in the non-coronary cusp. Now that is like the brim of a cup, and you can see that it's still in a sort of elliptical form. And what Nadeem will do now is apply some caudal to make that a straight line. You can see that's getting very close to a straight line, maybe a little bit more caudal. And that allows us to appreciate that the device is now in its most planar format. So Peter's going to advance that into the ventricle, and we might do a hand injection just to confirm that everything is as is. We'll do a cine acquisition there. And you can see that we haven't really altered the annular angle substantially. The pigtail is well embedded in the base of the non-coronary cusp, which forms a guide for us as to where we need to deploy the valve. We want to aim at 3 to 5 millimeters below this, the base of that pigtail.
So Ravi, there's two other things that I've noticed here. Firstly, there's a moderate amount of aortic regurgitation, which is probably in part introduced by the valve sitting across the native valve at the moment. The second thing is that we are hugging the inner curve. Can you explain to the audience how does that affect how we place the valve and how high we go on the non-coronary sinus?
So that's very important. Ideally, we want the valve to be as central as possible. If the valve hug is either the outer or the inner curve, it lends itself to tilting within the annulus. And so what we're going to do is readjust this to try and centralize it, and Peter will advance the system into the ventricle while I pull back on the wire, just to try and see if we can, or push on the wire. Just
push on the wire a little bit, and then I'll advance. So it's when Ravi is pushing on the wire and I apply forward pressure on the valve, it's not going to move in too far, but it may come away from the inner curve and centralize more than before. And that will be a better starting position. It doesn't always work, and I think in this case we're probably a little too deep now. Perhaps applying slightly more forward pressure, obviously without, and I think we just have to come back slightly. And so if we cannot get the valve off the inner curve, we will start delivering in this position, and we will try to be as high as possible on the non-coronary sinus with the disc that you can see there and the bottom of the valve, because when it's ultimately delivered, it will correct and it will drop down further on the non-coronary side and lift on the left coronary side. If you look at it now, it will be very high on the non-coronary, and if you take a straight line across, it will be quite low on the left coronary, but it will correct once we actually deliver the valve. So, shall we get started?
We should.
And before we get started, we might ask for pacing to help stabilize the heart rate, lower the pulse pressure, and avoid any ectopics whilst we're delivering the valve. So can we go on pacing now, please? 120 beats per minute, say, and we'll see what that does. And whilst we're waiting for pacing, the next step will be Ravi will start to deliver the valve. I will try to keep the valve position constant in relation to the non-coronary pigtail marking catheter so that we know we're in the right position. The valve, the Evolut R, is a very stable system, and so there shouldn't be too many problems with that, but ectopics and other things can interfere. We'll get started now.
Okay, so there's a plastic sheath that covers the valve, which is the first, so it's not the radio-opaque marker that is covering the valve at the moment. There's a plastic sheath that covers, and now that plastic sheath is just over the base of the valve. You can see that now passing it, and now I'll move relatively slowly to start extruding the valve, which will expand as it comes in contact with the annulus. So I'm going to stop there and do a hand injection just to confirm that our pigtail hasn't risen and that the valve is in a nice position, which, as you could appreciate, is in a very, very good position. I'm releasing very slowly here. We've got stable hemodynamics. The valve is flowering very nicely. And we'll just slowly release the device here. You can see it's expanding very nicely. Now there will be some parallax where the front and the back of the device will change position relative to each other, and we need to be conscious of that. We've got a very nice high position here, and we'll now be, I'll deliver the valve a little more, and okay, so we've now got a functioning valve, and we'll come off pacing now. So,
It's parallax free.
okay. So we'll now get rid of parallax, and by parallax we mean that the front and back of the valve, like that circular elliptical form, is removed. A bit more LAO there, and I think that's pretty good there. So we might just take a hand injection here.
Do you want to do a dry run first, just to make sure we have no parallax? So we could come a little bit more LAO, I think.
A bit more caudal, I think.
Yeah. Okay, we'll do another dry run. That's very nice.
Yeah. Okay. Are we ready for injection? Okay, very good. So now we can see the height. I'll let that play on a loop, and Chris will have a look on toe. And
Okay. So Ravi, we need to make a decision. What do you think we should do?
look, I think it's worth us going a bit higher with pressure on the wire to try and get it up to the end.
Let's do that.
So we'll get our pacing on again, please, at the same rate that we had to try and stabilize. And I'll turn this in the opposite direction to what we did previously. There will be a pressure loss initially, so we'll go reasonably quickly, and I think we're going to try and do a full recapture here so that we can reposition everything.
So I'll put slight forward pressure so we don't go all the way up. We may not need to.
All right, pacing on, please.
Pacing on. Thank you. Yep.
So you can see the sheath is re-advancing over the valve, and the valve will collapse back down into the sheath. We're going reasonably quickly. The pressure is now dropped. It'll come back again once the obstruction is gone.
Okay, stop that, Ravi, and then I might come up a little bit.
I'll press on the wire that we did it.
We can have a look here. Oh, sorry, may have just exited the annulus, but I can just...
Okay.
So you have to be a little bit careful going across now because the valve is not completely recaptured, and there's some sharp pointy bits at the end of it. I think that's a good place to
Very
start.
good place to start there. So let's try there, and we'll go slowly. I think keeping it as high as possible is very important here. The maximum diameter of the frame is at the base. We've got a very nice height here. I'll just do a test there just to confirm we haven't moved, and that looks very nice. And look, I think that's taken a very nice angle there. Just pacing off, please.
That's pretty good. So we're very high. We're definitely higher than we were before. You ready for an injection?
I'm doing a hand check.
Yeah, that looks very good to me now.
Chris, can you have a look now? We're very comfortable. We'll stop there. I think it's a very nice height.
Pacing off, yep. Yep, great, thank you. So we can still see a posterior leak here. It's probably at least mild, looking at this jet so far. It may not look a lot different to what it looked like before, but as I mentioned before, we may be battling a little bit against this very large lump of calcium on the non-coronary leaflet. And so I think it's maybe a bit better there. Chris, what do you think? And also the second point is that we really can't be much higher right now. We're about 1.5 millimeters, 2 millimeters below the non-coronary sinus. It really is probably not safer to go higher than that.
Can I just ask the panel at this point whether they would leave this, release the valve with this height and this amount of paravalvular leak? Or you might want to comment as to whether this paravalvular leak is acceptable in this lady, or whether you would try a third recapture and try and get a more optimal position, and what would that be?
I was going to ask you before, and perhaps as part of that answer, if I'm not mistaken, you didn't predilate, is that correct? Is that routine now at your institution, that you don't predilate?
For the core valve deployments, we don't routinely predilate unless it's bicuspid or heavily calcified leaflets. And here we felt that there was singular valve leaflet calcification and we didn't predilate.
You know, we would do the same now. You do probably end up post-dilating a little more frequently. This is an excellent position. I don't think you can really judge the severity of the AR until you fully release it. So as long as the position is good, I would be happy to release it. You might have to post-dilate to optimise the degree of AR.
Look, the reality is you don't have much room to come up. You know, some people have very, very short aortic-mitral curtains and there's just not much space there to move, and you can't come up any further, otherwise you're going to be outside. So you've got what you've got. But our experience has also been that, you know, in process, you can't really tell what you're going to end up with, and I think especially if you're going to post-dilate. And I think for the audience also, a lot of people, the perivalvular leak looks better on the first or second day post-procedure as well. So what you leave the cath lab with is not always what you get.
Yeah, I think this case illustrates one of the sort of bugbears of TAVI, and particularly of self-expanding valves, is nodular is asymmetric calcification that acts as an itis for paravalvular leak. And we didn't sort of see it after the first position, but probably there was moderate aortic regurgitation after that, and it's not changed a whole lot with the higher position because I don't think the mechanism was your depth. And that first position, the depth was reasonable. I think it was probably reasonable. Putting it higher gives you every opportunity, I guess. The key element for sort of combating this sort of paravalvular leak are the adaptive or seals or wraps. They've made this, I think, the most inroads to this sort of issue, and the better seals that are available on some of the devices probably make more of a difference. Was this an Evolut Pro, for example?
This was an Evolut R.
Yeah, so I think this sort of case, if we did now, we'd say we'd like a Pro for this because there's nodular, asymmetric or eccentric calcification in that aortomitral curtain, and a skirt will impact that. The problem with placing the valve higher now is that when you go to post-dilate, you may in fact bring the valve up even further. And you know, it's not as big a problem with core valve, but say it was a portico, you know, you do run the risk of sort of post-dilating and then raising the valve even higher. So if you go very, very high and you're going to post-dilate, you just need to bear that in mind. But I would have thought probably you'd obliged if there's moderate AR to try and post-dilate, see if that has an effect. You're not going to get any benefit from the subsequent effects of the skirt because you don't have it in this case. Certainly looks better the next day, and that's because the self-expanding valves continue to mould the annulus. And sometimes it's because you just don't see the AR as well post-op for a transthoracic edge.
I think, Darren, the panel made some very important points. I think post-dilating, this is a metallic frame, and as you dilate it, I mean, you're trying to achieve as high a position as you can to minimise the leak. But the danger with being too high is as you expand it, it shortens. And so if it shortens from the bottom, there is a theoretical risk that you then have part of the frame, or a significant part of the frame, that's supraannular and increases the risk of embolization. But anyway, I'm not sure what we did here, Peter, so I'll let you continue with the video.
Okay.
Especially if we're contemplating post-dilatation. So I think we'd probably be happy with this. What do you think, Rowan?
I think this is a perfect position. And as you say, we're contesting a structure which is not perfectly circular, that's got ridges of calcium that the valve may not expand against. I think this is as high as we can safely implant. I get the sense that the toe looks better than the first one.
Yeah.
So I think we should probably deploy this valve. I think we're very happy with the height, and we can reassess the leak after we've deployed, and if we need to, we can post-dilate. So I think that's certainly. So we'll get the pacing on again, just so we can stabilise the valve. We don't want ectopics as we're releasing this valve. And what I'm going to do is pull back on the wire so that the nose cone, again, is biased more towards the centre.
And I'm going to lean forward on the valve a little bit.
And can we just centralise the frame, please, so we can see the top of the frame, which is where the hooks are? That's wonderful. And we'll release slowly now. Okay.
And again, there's no rush in releasing. You can do it quite slowly. You've got a functioning valve. I'm struggling to see it then.
That's
okay.
good, yeah. And the tabs are off, so I'm just going to now go all the way to the end until I get a clicking sound. And now we've confirmed that we're off, so I'm going to pull my wire back. And
so now we want to free the nose cone to make sure it doesn't interact with the valve. You could embolize the valve that way, so we just come out very gradually, very slowly. And then Ravi will now advance the wire whilst I'm withdrawing the device. And then we'll come to a lower magnification, please.
Okay. So Chris, do you want to have a look at that, please?
So Ravi will recapture the valve and just move up to the top, please, so we can see the top of the valve. Thank you. And just a copy, maybe a bit too far. Perfect. Okay, good.
To assess this, there's three ways we assess paravalvular leak. We look at the echo images, and echo is not perfect in this regard, but it certainly gives us good guidance. We do aortography, and we want to limit how much dye we give patients, so we don't routinely use a lot of dye. And thirdly, we use hemodynamics, which provide us some guidance. So what we'll do is we'll take the device out. I guess the most important thing here is to see the separation between the diastolic pressures. And they're indeed very similar to what we had at baseline, I guess is what we can say. I agree that we'd like it above 25. And I guess the question for us now, based on the toe, and Chris might just show us another toe image, is what to do now. Do we allow this valve to expand over the next 48 hours, or do we give it, do we post-dilate it to allow maximal expansion? And so Chris will, now that we've got everything up, we can just wait and have a look. Assessment of paravalvular leak is difficult. Here you can see the leak posteriorly, but it interacts with the mitral inflow. So, ready?
Inject. I think that's probably mild to moderate as well. I don't think it's moderate. It's definitely not severe. It's probably mild to moderate. I think post-dilating here is not a bad idea.
Agree. So we've got a wire in position through the sheath. We've got our left ventricular pacing system nicely positioned, and we've got a parallax-free view to help us guide us as to where we need to deploy the balloon. And make it up, please. So we're just going to be a couple of millimeters below the base of the valve because the valve will expand. We've got an inflation device here which we will prep. And Peter, we've got the wire nicely embedded in the ventricle. And okay, so we've got hemodynamics on here, and I'm going to make a connection to the screening on, please. So I'd like you just to focus on the hemodynamics, and now I'm going to connect on the pacing. You can see the pacing has started. Not getting quite good capture of the ventricle, so we're just going to be getting good capture there. So I'm just going to expand the balloon nicely up, deflating the balloon, and Peter's just going to disconnect.
So just what was going on there was we were using the wire in the left ventricle to invoke rapid pacing. So usually we use a temporary wire in the right ventricle, but you can also use the wire in the left ventricle, and that little stuttering in the beginning was just inadequate wire contact with the left ventricular surface. So I'll let that go on.
And the pacing is off there. So it looks very similar, and what we might do is fill the balloon up with a little bit more fluid.
I think due to the LVOT and sinotubular junction calcium in diameters, they're quite small, the short diameters. I think we used a 23 on this particular one.
And try again. You can see that was quite an easy inflation.
Okay, go. Yep, go. All the way. And down.
So with the first inflation we noted we didn't really get any expansion of the frame, and with this time we filled it up with some more volume and took it a bit higher, and I think got a slightly
And
better
pacing off, and we're off pacing there, and there was quite a nice inflation. You can see quite a nice. So I'll get this out now. What we'll do is just deflate the balloon more, and we'll get the pacing wire out and do some more hemodynamics. The balloon off and do some hemodynamics. We'll get the. Chris, you can have a look now.
Chris Chung's our toe operator, just in case there's so many references to him.
Post-dilating in this situation does give you an opportunity to mould just a little bit. And it can take a moderate leak down to mild, and it can have a modest effect. I guess, what is the downside of dilating? The downside is you run the risk of dislodging or embolizing the valve, although that's low, but you need to be aware of it particularly if it's a high implant. And if you lose pacing during balloon inflation, that's the commonest reason for causing embolization. So making sure the pacing is reliable is really, really important. And I guess the only other thing is occasionally, with a self-expanding valve, if you're ever going to rupture an annulus or cause a annular rupture or hematoma, it's in this situation where you've got really spiky nodular calcium that we're currently dilate, that we've seen that happen. How do you size, would you like to describe how you size the balloon in this situation?
So we would have sized it, bearing in mind the left ventricular outflow tract diameter, smaller diameters. If there was any calcium in the short diameter at the annulus level, we would certainly take that into account because stretching it, that is where it stretched the most. And this lady had about 50% of the perimeter of her sinotubular junction taken up by calcium with a diameter of about 24.5 to 25.5. So we were a bit concerned about going too high as well. And she's a very small lady, weighing between 45 and 50 kilos. And so you have to take all of this into account. But basically you work it out on your pre-TAVI CT measurements.
And those comments are very relevant because in our attempt to achieve the best possible aesthetic result for this lady, we have to take into consideration her comorbidities. She also had mild to moderate or even moderate pre-existing aortic regurgitation, so the likelihood is that she's going to tolerate this. Her main pathology is aortic stenosis. Now, this patient was high risk or low risk. It's a different ballgame. This is a high-risk patient, and so how much degree of paravalvular leak we accept is perhaps an important factor to think about.
I think we gave that a really good inflation, and I think, and hopefully that will translate to something that improves.
This is where you need your echocardiographer to be kind to you.
But I think it's important to balance the benefit and risks here. I think to go to a bigger balloon probably is not safe with all the calcium and small sort of size of this lady's annulus and LVOT. So, and there's also calcium in the sinotubular junction. So I think we've achieved something, and we probably just have to be happy with that now.
Absolutely. So what we're going to do is we're going to measure pressures, maybe do another aortogram data just at the end to see whether one more aortogram, and then we'll probably finish from a device point of view. I think we've got a very satisfactory result. It's been done fairly easily, you'll agree. There's been quite easily positioned. We've been able to optimize the position when we weren't happy. We were able to move it 1 or 2 millimeters, which shows you the relative precision of this. So quite a straightforward procedure. It requires a lot of planning and a lot of adaptation during the procedure, because clearly things change and you need to make decisions on your feet. Looking a bit better there, Chris, I'd say. Okay, so let's do the hemodynamics again. And the other thing that we look at is to see if there's any significant residual gradient across the valve, and certainly here, if anything, there is no forward gradient. And the diastolic separation looks nice.
Just Baron and I both noted there's some valvular AR as well.
Yeah, that's our wire still across, and so that almost universally disappears at the end of the procedure. We might stop here. This is essentially the final result with what we thought was mild plus mild to moderate at most, paravalvular aortic regurgitation, no systolic gradient. On both hemodynamics, the aortogram, and the echo parameters, at the time it looked mild plus. Panel's welcome to make
I was just
comments.
going to say comment on the hemodynamics. The diastolic pressures come up from the low 40s to the low 50s, so I think you have made a difference hemodynamically. Of course, you have to correct that a little bit for the heart rate. If the heart rate goes up, the diastolic pressure will also go up. But it does look hemodynamically like you've got a better result, and I would accept that in a 90-year-old, particularly if you had a bit of AR at the beginning. I think it's great.
Yes, you had roughly the same degree of aortic regurgitation prior to starting, still most likely therefore tolerated relatively well.
Why do you think that data about residual or aortic regurgitation, even mild, seems to have such an impact on prognosis? I mean, that always surprises me.
Sure. I think that the studies have been a little, they don't all agree. Some studies have shown that mild, moderate but most of them have agreed that moderate to severe is a very bad thing, and that clinically certainly has been borne out. If you have a trivial or mild leak, we really haven't seen any downside to that. If it gets into the moderate and there are other factors, such as no pre-TAVI aortic valve regurgitation, then we've certainly seen some adverse outcomes there.
I think the other issue is that a paravalvular AR is very difficult to quantify, and often it's difficult to know how much moderate paravalvular aortic regurgitation is actually worse. And I think there's a tendency to undercall them in that situation. So that may sort of give some explanation as to why the moderate paravalvular leak carries such a bad thing.
But I think it does matter what the ventricle looks like. If the ventricle is very thick and stiff, they really don't tolerate AR as well as if the ventricle is more pliable and normal. So I think you do have to take that into consideration in terms of how hard you're trying to do it.
Sure, and we were thinking about that in this particular case. You did have a degree of diastolic heart failure before coming into this. And okay, in fairness to the subsequent speakers, we might stop here if that's all right. Okay, thank you very much.